We've begun. Well, first we have announcements. You ready for announcements? I, I don't. We have a sufficient time and material to not have to stick around late for lab. Unless you seriously want to stick around for lab after 4:30. No, you don't. She's talking to Dr. Dress. We realize that. So no, we will not have lab today or next week. I'm not planning. We have enough to have ample time to get through it. Okay, there's not a problem, particularly when I did. And it's an interesting decision. I just felt that you have enough content and enough material that'll give. You can use the extra time to make sure I get all those. There were going to be presentations. Now they're going to be reports. So now there's extra times associated with that. We're not having lab this afternoon. Saviors wasn't going to come anyway. Yes, sir.
I forget if you said, is there going to be a curve
For the what? For the third?
Yes.
Isn't it already there? Or I didn't put the curve grades on it? Well, I don't remember doing it. Didn't I put the curve grades on? I think I did. Didn't I?
I don't think you did though.
Okay, then I'll do that when I get home. Yeah, and the answer is yes. Some curve. There's a petite curve. Un petit curve. It's not a curve much as maybe just a general wave. You'll see it when it's there. And on that note, if you're mad about it, TFV, because I won't be here till Friday. You don't have me to kick around on Wednesday. I know it's upsetting. TF bad, too bad. You figure out the F. Why is that hard to understand? You never heard of that? WTF not? No, you can ask me what that means?
Yeah. No, I know.
They don't say, God, we really have to educate you.
That's why we're in school.
But that's what school is about. We're talking about like that street smart stuff, yeah.
Can't have it all.
Yeah, I understand that. So nobody cares. Nobody thinks you're funny, Lou, so stop talking. No, I'm not going to be on campus Wednesday or Thursday. I'll be back on Friday. And I mean, so I'll be email reachable, but we have stuff to take care of down in DC. So just for a quick overnight. Maybe my wife and I'll be back. And then, oh yeah, but I'll be here all next week and right through finals and everything else like that. Aren't you excited? Yeah, finals make you excited. We can get the heck out of here. All right, so I'll get all that done, and I'll see what recording or whether I'll just have a finals based recording and just work off of that. We'll see. So I wanted to finish up a little bit about urinary at the very end, okay, and then get on with repro. They are hard topics. For the folks in MCAT today, we had that two of our students from last year who are at are hoping to and I think likely to get into Duquesne's osteopathic medical program. Spoke with our MCAT students today. Some of you are certainly part of that. But I mean, they talked about the emphasis point. Repro and kidney are hard. That's why they ask a lot of questions. To the physiological, the anatomy is not nearly as hard to understand as the physiology. If anything, when we get to repro, the male anatomy is a little more complex. The female anatomy is not terribly complex, but the female physiology is very complex. So all that's kind of what we're leading to with this. Just the same way renal physiology, even though we're pretty much through that, is fairly complex. So let us begin. So here we have, this is the part where I don't know where we ended per se. I remember we were talking about urine and things like that, but this to me is not a big deal to go into what it is. I know we mentioned about glomerular filtration and things like that. The exact composition of urine, fine. Again, the principal thing that we have are nitrogenous wastes. That's probably to me, that's job one. Nitrogenous waste removal. All the other things are we have a certain amount of all of these different kind of solutes that are found in there. and we look for things that shouldn't be there when you dipstick your urine. If you the presence of any of these things have to be investigated, unless there's a particularly an obvious reason why it might be there. It's there, and there isn't a whole lot that you can think of with any of these things. And it's really white blood. It would be maybe having had being known to be recovering from a condition where you had these findings and they're steadily going away, that would be acceptable. Other than that, you have to figure out why they're there. It isn't usual. And down the road, anatomically, just to amplify the point, because of the anatomical differences between men and women, any findings are highly suspicious. In women, depending on the ability to obtain a clean catch or an uncontaminated urine is a little bit more challenging. It's there. When we're doing it in a hospital, it's a little bit, typically, if you see an occasional bacteria, just the anatomical nature makes it more likely to pick up accidental contamination. That's why we do things called colony counts. I mean, if you have a trace of bacteria and you do a colony count and there's only a small amount, not a lot of colonies, then that's just an accidental contaminant based on getting the specimen, as opposed to when you get something called TNTC, too numerous to count, that's bad. Then you have a full-blown infection. And I say this to you when I do in the next part, you're not at the age yet where these things can start to happen. With women, we would probably see more problems associated with it than men. With men, things start to catch up with about age 40. My middle son is very healthy. He's a big, strong, for his high 5'11", 190 type of guy who works, lugs around propane on a propane truck, climbs all over stuff, for the last X number of years. I mean, and he recently has had he had some kind of bladder-oriented infection, whether it was bladder or kidney, and it wasn't clear. Maybe it was a stone that didn't show itself on the scan. They don't know, but it's treated with antibiotics down there at 40 years old. It's going to be 41 May 31st. So I didn't get to see any of that stuff because he moved down to Florida, and they were just communicating by phone or text. Nevertheless, these are the kinds of things you look for. There shouldn't be any sugar in there. That immediately you think about that. Proteins, I mean, as you can see, it can be, somewhat recent physical exertion, pregnancy. But when we begin to see certain numbers, then we have to start looking at things like that. Ketone bodies, again, diabetes, starvation, but that would be evidence for other reasons. Anything like that, we see hemoglobin, bilirubin, you're looking at liver disease. Again, unless there's something extraordinary, like someone had recent trauma or a recent infection or a history of a stone, then you might expect to see erythrocytes, and you never would expect to see white blood cells. So so we do typically a dipstick for a microscopic, and we do a dipstick and you get various levels. It's kind of like if you've got a pool and you're checking chemicals, you'll be +1, +2, +3, +4, and you respond to it accordingly. Those types of things. And then also typical urinalysis will do a microscopic and do a quick scan looking for red cells, for white cells, odds and ends, things called casts, CASTS, which indicate proteins, crystals, which make you start thinking about a stone. So these are all things like that can rear their ugly head. Yeah, it should be clear. Cloudiness tends to indicate white blood cells. Like, the color varies with how hydrated you are, but and you can see, if you see abnormal color, most of the time the implication is maybe typically blood or bile pigments. Certain medications and certain foods certainly play a role, and that's where historical questions are. For instance, there's an over-the-counter product when people have urinary irritation called azo. I forget what the chemical is. It just sort of, for whatever reasons, over the counter, and it calms urethral irritation, which is relatively common for a variety of things. Okay, with relatively minor urinary tract infections, but it creates like an orange color. It's very distinctive. Things like that. Do not do this because you're in a university. When we used to, oh, we're terrible. We used to like, you could inject, like if somebody had like Skittles or that type of a candy, you could inject it with things like methylene blue, and their urine would turn blue. That's what you get when you're a chemistry major. You learn stuff like that. Evil. No,
It's gotta be a yeah, but
it's
it would be fun.
you imagine the person screaming, ah. Okay, you have to understand. That's why we happy we don't have a chemistry major here. You get more people like me and Dr. Badger, who are let's face it, a little mature.
Dr. Badger just hides
What?
it a little better.
What?
Dr. Badger just hides it a little better.
Oh, he's oh no. MacGyver, hardly. We're cut from the same cloth. He's just more technically gifted than I am. When your secret advice is, he's like me. He's probably watched every Star Trek episode, knows everyone by heart. He's named the characters and everything. The odor, it depends. Odor is interesting, and again, certain foods will produce an odor. Certain medicines will produce an odor. Diabetes, you get ketones in there. Ketones have like a sickly sweet kind of a smell. Yuck. Different diets can affect it. Specific gravity is something there's like a dipstick test that you can determine, and that basically tells you what the proportion of water and solutes that are there. So it has to be in the normal range. This is anatomical. But the reason I'm saying it for a reason, that's this reason. Inevitably, if it's something that's important to the person who's teaching the course, be aware of these questions. Transitional epithelia, where my bladder cancer was. The epithelia of the bladder and the epithelia of the ureter is transitional. Transitional ends pretty much as the urethra gets into the spongy portion, the external portion, in the urethra of the male and of the female. Okay. Effectively, once that occurs, then we make the transition to stratified squamous non-keratinizing. Then you're dealing with the force of the flow. But transitional is just that. Transitional is a stratified epithelia. You might remember this from anatomy. It looks like we have more layers or less layers. The transition is an optical illusion. When the ureters are filled or the bladder is filled, it flattens out. Okay? So it looks like there's maybe 2 layers. When the bladder is empty or the ureters are relatively speaking empty, okay, then it expands to maybe 7 to 12 layers. The difference with why we know it's transitional, it has rounded, the tops are rounded, the cells all have nuclei. So it's not, that's how you distinguish it from things like stratified squamous, be it keratinizing or non-keratinizing. Okay. Smooth muscles. Okay. Contracting lineage, stretch receptors, peristaltic waves. Therein is physiologically what happens is peristaltic waves, just like we get a baby with a colicky baby, urethral colic, and that's what we call it, is what happens with a kidney stone. You're going to see the anatomy. There's these tiny little nooks and crannies where little particles can get stuck and they irritate, and the spasm creates a colic that is extraordinarily painful. And in the male, the referred pain is directly into the penis. By the way, if you remember that referred pain chart we did a while ago, that's where it goes. So it's all of a sudden you get somebody come in emergency room, it's like, oh my God, and they're, and that's why I thought my son's was a stone, because that's what he was describing. Oh my God, I gotta get to urgent care. That type of a thing. And he did. And then thankfully, whatever they treated with has been effective. So the peristalsis is there. And so this is what I mean. These are little spots where a crystalline can just get into these little areas, and you can almost see. You remember what the esophagus looked a little bit like that. The epithelia is different, but it can expand when there's fluid, and it contract when fluid is with the absence of said fluid. So here are the stones. We call it the nidus. Nidus is the core of the stone. It can be blood, it can be calcium, it can be bacteria, it can be uric acid, it can be magnesium. Okay, it doesn't matter. There's different things for different people. I would dare say in women, we tend to see bacteria and blood maybe a little bit more. And you really have to be careful with calcium. I think it's important that vitamin D and calcium levels are maintained. And most of the time, if you're taking vitamin D, it comes with calcium supplements, Caltrate with vitamin D. The calcium is calcium carbonate. That's what's in Tums. Okay. There are certain calciums you don't want to play around with. So if it's calcium carbonate, that's what you're looking for. In the old days, we called that Oscal, which was oyster shell calcium. Now we just call it calcium carbonate. So, all salts are not created equal. And so whether it's and stones, as you can see, can go there. Again, uretro, beg your pardon, not uterus, but uretro. Lithias is stones. Lith means stones. Most of the time they pass. It's the same thing like with gallstones. Years ago, it was horrible. And you folks are, the guys particularly, you're not there yet, but you're getting closer. Once you hit that, once the number with the 3 gets you, you're starting to enter into that territory. 30s to 40s is where is stone time. Okay, that's when they start to rear their ugly heads that are there. And so, and a lot of times, this is where the lithotripsy comes from. Those high frequency sound waves. Because it would be very difficult. The surgery would be problematic at best if you had to do that. And so it breaks them apart until they're like a little bit of a dust that are there. There's a lot of different risk factors. Foods play a role. I distinctly think so. And dehydration plays a role. Maybe him being down in Florida now, maybe playing a role with that. But he's always been pretty good with hydration. Now he gets to the bladder. It's a storage sac. There's nothing to it. We'll see some of the illustrations. Pelvic floor, behind the post-pubic symphysis. In the males, the prostate is inferior to the bladder neck. Okay. Females, it's anterior to the vagina and the uterus, as you will see. The locations in both. The big deal, bless you, is that the two ureters enter and the urethra exit in an area, and obviously a triangular area that they name the trigone. Just like the stomach, when it's empty, it contracts, okay, the accordion pleats, and it has ridges that they call rugae, just like the ones in the stomach. And when it stretches out, they flatten out. The problem is where infections occur, because that flat area of the trigone, if there's any type of urine tends to stay, and if anything, if there's bacteria in it or something that might lead to infection, that's where it tends to persist in that particular region, in that trigone. Okay, the transitional epithelia, the really important muscle that's so strong, is a very, very thick, smooth muscle with 3 layers called the detrusor. Okay, and then the adventitium just means it's not designed to move. We find that in retroperitoneal substances. Here's the male. There's your trigone area. That's there. So you can see the openings that are there and the exit point that's here. And here's the unique feature of that. And this leads us in to basically what we're going to do, male repro. That's there. The interesting part is that it immediately, and we'll review the anatomy, because it's so important to understand the physiology. Okay, it basically becomes the prostate, for lack of a better word, surrounds it. And so you have the confluence of fallopian tubes. I'm in class, doofus. Okay. I beg your pardon, the vas deferens or ductus deferens tubes enter. Here's the ureters entering. But in the male, they entered. Remember, we'll review the anatomy where you begin to see how they join first with the seminal glands. But effectively, that prostate gland is a large comp where it performs the prostatic urethra It picks up the prostatic secretions. Then the membranous urethra, and then you can see those bulbourethral glands, which are lubrication vis-a-vis when we start talking about how sperm are ejaculated. Okay. You can't text. I know you can't text. Hold on. Don't have children. So here you have this. Okay, that's there. Then you have the bulb. We call that little area the membranous urethra. And basically, it's the transition from within the abdominal peritoneal cavity to without. And then you get the spongy urethra afterwards. So it's an elongated segment. And unfortunately, length has its own subset of problems that are associated with it. In the female, it's shorter, which accounts for a certain subset of problems. In the male, it's longer, which accounts for another subset of problems. It's interesting how that works. So we'll get to all of that. Here in the female, we don't have anything. We have urethra. So it's transitional epithelia here. In the male, it's transitional. It's probably still transitional. Once you get through the membranous, now we get to that. We leave that and we get to stratified squamous non-keratinizing. In the female, it's almost an immediate transition afterwards. So collapses when empty, rugae appear, it expands significantly, during filling without significant rise in internal pressure. So a full bladder, look at this, 5 inches, and can hold easily 500 ml. That's moderately full. I mean, a full bladder can hold more than that, well over a liter. And it'll be very unpleasant. I hate talking about this stuff because it happened to me. When I had my initial bladder cancer surgery, it blocked. I should have had a catheter in. I was against it. The doctor's great. We had a nice verbal battle, but we spar all the time. Maybe the best physician I've ever had. And I ended up with it blocked. The worst pain I've ever experienced. They pulled off about 1.5 liters of blood. It almost exploded. I've never been in such pain over it. And this was a big deal over at Allegheny General at the emergency room there. To give you an idea. So what they do, if you did not know this clinically, they do what's called a urogram. You work as a nurse's aide or something like that. You do them with patients it's a simple ultrasound that you go over the bladder area, and it basically tells you what's the residual amount of urine. I mean, if it's under a certain number, it's fine. They emptied their bladder. If they didn't, that's significant. And that's a pretty routine test they do all the time now on the floor in almost any kind of facility. So you can see it can hold twice that amount necessary, but it can burst. And I was an over-distended hole. And this just gives you an idea how it outlines it with dye. This is really a variation of what's probably not a CT. Probably it's a colorized intravenous pyelogram. Okay, again, here's the urethra, mostly pseudostratified, columnar, transitional near the bladder as it gets here. So you can see the transition as it goes from transitional, hating to be redundant, to columnar and then stratified squamous is what they're pointing out. Sphincters are there, different in the female. You can see this, that's anatomy. That's there. Lots of things to answer the problem. Hygiene is inappropriate. The short urethra females, unfortunately, and the anogenital region with proximity is a big problem, particularly in people who are incontinent. I can't say it enough. There. Most UTIs occur in sexually active women. Okay, when they're elderly and infirm, we get the incontinent ones. Here, this is certainly the primary source. 40% get urinary tract infections. Not most of the time. They're typically I'm trying to think of the right way to express it. we see more of the relatively tame yeast infections, which have to do with a variety of things. They can do with, medications can induce it. There can be some people are unusually prone to it. They are relatively easy to treat. They are not problematic. They are not sexually transmitted. Generally, during intercourse, the male would be unaffected, or whatever kind of intercourse the partner would likely go. Would be a better way to express it. As you can see, intercourse driving the bacteria vaginally in the external region toward the bladder is just a mechanical process. And interestingly, spermicides magnify the problem. It's interesting. I don't know if that, again, this is 8 years old, if they have rectified this problem in certain types of spermicidal gels. I don't know what the preferred things that folks use today for pregnancy prophylaxis, other than like pill and things like that. It's one of those kind of trendy things that happens over years, like that. I'm gonna kill it. Hold on. Hold on. So I do not know. So urethritis, cystitis, if it gets up to the kidneys, pyelonephritis, all of them. Constant problem, whether it's sexually transmitted or non-sexually transmitted, frequency, urgency, feeling like it didn't empty the bladder, changes in the appearance of the urine, fever. Now when we start to get to fever, it's a little bit more significant. And typically when it gets to the kidneys, we're talking about back pain. And I have no idea, though he's nagging me now. Antibiotics typically are the treatment of choice for all those. And there's not a whole lot. I don't really care about the mechanisms of urination, what we call micturition. Okay, all those things, not a big deal to me. What the reflexes that are involved, etc. There's different things that can, it tends to be more of a problem as folks get older. Okay, and yeah, another thing that you'll see a lot of is that pelvic floor, and women who have had particularly multiple pregnancies, and there's some hereditary event. We see pelvic floor weakness. I think I told you there's a whole department dedicated to this at McGee. Pelvic floor and pelvic floor reconstructions. They're very common. People used to call them a bladder lift. I know when my mom had one, it was one of those. It's not easy at all. They did one on my late mother-in-law, who had I would dare say she was in her 80s when they did that. Probably she might have been maybe 88, 90 years old when they did that procedure. It wasn't that terribly long ago. I'd say somewhere between 85 and 90, my best recollection. Okay? So I mean, age does not. But she had a lot of problems with that, and she had a number of recurrent bladder problems. A lot of times, that's what put her in the hospital up until the last 3 or 4 years of her life. And so you can see problem.
I have a question.
Yes, go ahead.
So pelvic floor reconstruction, as in like pelvic floor prolapse, is
Yes.
that directly related to bladder problems?
No,
Not
it's probably
just
related more
muscular?
pregnancy playing a role in that. Inherent weaknesses, hereditary weaknesses, weight problems potentially could have. There's a lot of things. My mom was never slender, as far as I know. Parents didn't tell you stuff back at my age, so as far as I knew, it was just my sister and I. Whether there was a miscarriage somewhere along the way, there's nearly a 6-year gap. Back then, you didn't have another kid unless if you could afford to have another kid, because they had grown up in the Depression. So I don't know, and I'm never curious. I have a cat at home who takes care of it. He has never gotten that message about curiosity in the cat. This morning, 4 o'clock in the morning. Why do you have to go outside? We finished that. Moving on. So that's the best I can tell you. Moving on. So it brings us. Please stop sending me stuff. Let me see. So I don't want to rebuild with everything because you had the anatomy, and I'm not going to go crazy with it. I'm not going to do meiosis. Okay, reason why I'll talk a little bit about it when we get to the female, just because of polar bodies, understanding when different events occur. I think that's important. Okay, the first sentence says it all. It's different. Okay, because we're only dealing with it in males. Once it's active in puberty, effectively it's active for a lifetime. In the female, of course, it's active, becomes active on or about puberty, but there's effectively a lifespan where when menopause occurs, and typically mid-50s seem to be about, current numbers are about that. You can look online and find current numbers. To my way of thinking, male is more complicated anatomically, a little bit easier to understand physiologically. The opposite is true. That's the way I think about it. Yeah, we know all about these things. Okay. Primary organs, okay, the testes and the ovaries, everything else is an accessory. We talked about that before. Specialized cells, whether it's sperm or eggs, fine. Those are the gametes. We know that terminology. Yeah, the context that I will give you physiologically with this, and it's by no means as I framed it before, it is not my long suit. Where I'm pretty good with kidney and I'm very good with things like blood and muscles and nerves and digestive and all that type of stuff. This is not my long suit. My context, the way I think the best way to understand it is what it's supposed to do. The whole idea of the reproductive system is successful reproduction. So I know more about it from what went wrong than what went right, since I didn't have successful reproduction. And it's interesting that without any medical history on my eldest, that he and my daughter-in-law went through something similar. I was never curious to see why that occurred. So I was just happy to have the two grandkids. So the whole idea through sexual intercourse or copulation, fertilization, formation of the zygote, okay? And I do a little unit at the end that we'll probably get time to do at the very end of next week, sort of the growth and development unit, and gestation and parturition. So the question is, how many times the person was actually, and how many times they actually gave birth to the baby? In other words, for whatever reason, the pregnancy did not develop into the birth of the baby. And, whether that was by intent or by accident or just unable to sustain the pregnancy are all different issues that are not really part of the course that are there. With anatomy, I'm all big on homologous structures. I don't need to go through that. We know all the terminology that's there. This is when we start to look more closely at the effects of the steroidal-based hormone, the testosterone, the estrogen, the progesterone, and the roles that these things play physiologically. This is the same point that was made earlier. And the point is this axis. The hypothalamic pituitary, it's the classic axis, just like when we looked at thyroid or whether it was antidiuretic, it doesn't matter. This one's very, very specific. Okay. So this has to do with sensing in the hypothalamus, the very important hormone of GnRH, gonadotropin release hormone. That's one of those posterior pituitary. Remember the exam thing and all that? For those that are still awake, I should turn the lights on. I think you're too involved with sleep. FSH, LH, testosterone, da. So the big player here, GnRH, gonadotropin release hormone, from the hypothalamus, posterior to anterior, away that portal system. And what does it trigger? FSH and LH. follicle, eggs and sperm, luteinizing all the hormones from the anterior pituitary. Obviously, testosterone in the male, estrogen and progesterone in the female. The limited amount of testosterone-like substances, as you may recall, in the female come from the adrenal cortex. That, whatever that is that the reticularis or the fasciculata? I think it's the reticularis off the top of my head. Okay, inhibin, release from gonads of both male and female. That's a negative feedback on follicle stimulating hormone. Okay, as if to say, we have a sufficient amount of eggs and sperm activity. Thank you very much. So as you can see, it's a well understood, but that doesn't mean it's not without a lot of faults. Every time I teach this unit, it's miraculous to me how it works right. It's such a complicated process. And I'm more amazed when people are able to conceive as opposed to when they are not sometimes. So sex hormones, the presence of estrogen, testosterone, progesterone, and the inhibin negatively feedback on the anterior pituitary, negatively feedback on the hypothalamus that are there. So how does this all occur physiologically speaking? When the reproductive organs grow to adult size and become functional, puberty. That's theoretically the earliest time that reproduction is possible. It is highly unlikely to occur. Highly unlikely to occur during the first time an egg is produced in the female or the early production of sperm in the male. Highly unlikely. That does not mean impossible. Okay, and so you can see it become functional earliest time that is possible, underlying the word. Low levels are enough to suppress. That's the interesting part. Understanding why it triggers at certain ages. Anecdotally, it's happening early. Does it have to do with materials that we put into the food supply? A lot of people think that. The same way the development of antibiotic resistance from a lot of the antibiotics that now we have much more of a tendency to see things that are like the chicken we're making tonight, antibiotic free. There's a lot of slush about it. So in an effort to improve our food supply, we have introduced a lot of things in it that we think have played a role in things like infertility. Maybe they've played a role in other things. Certainly they may have played a role in the early start of the process we call puberty. But it's sufficient, at least whatever the age it starts, there's enough GNR are enough to suppress very low levels. As puberty approaches, this is one of those interesting phenomena that we really don't have a way to say what makes it happen, what makes the hypothalamus less sensitive to the inhibition, and it begins to magically release this GnRH. When you talk about pulsatile, large amounts are coming out rapidly to trigger the onset. So the anterior pituitary releases FSH and LH. They stimulate the gonads, release more sex hormones from the gonads. The threshold of inhibition continues to rise, resulting in more and more release of sex hormones. Okay? It just keeps going and going. Okay. So you get into this, it's not like it's just misunderstood. Like I said, we don't see a lot of positive feedback. Blood clotting, and a ton in this particular area, whether it's the onset or whether it's even part of the actual reproductive process. And they are released by this way until eventually we get to the quote-unquote adult pattern. Okay, we know about meiosis. The whole idea about mitosis is very simple, identical copies. Mitosis is all about getting it the same thing over and over again. Meiosis is all about diversity. So what are the hallmark events in meiosis for diversity? We all know this. You all had cell-molec. You all had that stuff, right? Crossing over, chiasmata, synapsis, whatever you want to call it in prophase 1, right? That neat little exchange that takes place with the arms. Oh, I got some of yours. You can have some of mine. And the law of independent assortment. Forwards, backwards, forwards, backwards, 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 forward, forward. 23andMe. Ancestry.com. So it's a reduction division. You know, we don't double and split twice. So we double once and we split twice. And so, and then the same thing, I'm not going to go crazy about this. That's just a wrong thing. I don't love doing it. So when we talk about the sister chromatids, the two sister chromatids, they're joined by the centromere. We all know that, making them easily visible. And then they form the homologous pair. Okay. And so, like in that, from from an MCAT perspective, you've got to know these. I'm not going to go crazy and ask people about this. Just no. As to technically when we have completed one and not. So what concludes it, etc. There's a lot of that goes on that are there. So the terminology. So the homologous pairs, chromatids of one chromosome and non-sister chromatids, the other chromosome of the pair. And again, they form what we call a tetrad. 4 of them. And we know the ones in the middle cross over, increasing genetic variability. Okay. You all know diploid and haploid. We know what haploid is. And then they fuse and they're back to diploid. So you have effectively 2 divisions. DNA, the replication occurs first, but we divide twice. So at least in the male, we get 4 haploid daughter cells. Would that be son cells? I could change it. Could write a paper. Prophase, metaphase, anaphase, and telophase. Okay, we know all about those that are there. And so you can go through all of this. So meiosis 1, the pairs separate. So that's the reduction division. And then we get the sister chromatids. And effectively from 2N to N. So now when the homologous pairs, now we get down to N. So theoretically, that's a different division than we have eventually referred to as the equational division. Don't care. Don't care. Don't care. Big deal. In meiosis 1, that's when we reduce the chromosome number. That in prophase 1 of meiosis 1, and there's a zillion names for this: synapsis, crossover, chiasmata. Again, I would be very generic in that question if I would ask you. That's the unique chromosome pattern that's there. Metaphase 1, tetrads line up randomly in spindle equator. Okay. And so that law of independent assortment occurs, and then we have the separation of the sister chromatids to complete. At the end of meiosis 1, the daughter cells are there, etc., etc. Okay. DNA in each chromosome. Haploid chromosome number, because still united sister chromatids are considered one chromosome. So that's the part I was making. At the end of meiosis 1, it's still considered haploid, even though which the sister chromatids are considered as one. That's one of those back of your mind things if you're going to take the MCATs. Say this there, blah, blah. They go through all of these. Chromosomes are not replicated. Okay. Cells undergo meiosis 2 are haploid by definition, not diploid. So at the end of meiosis 1, we go, again, as I said that. And we get 4 daughter cells. We're looking at the male particularly. They're going to look at it differently when we get to the female and where it's suspended vis-a-vis meiosis 1 and things like that. Mitosis, okay. Identical, meiosis, genetic diversity, all those neat things that occur. So how do you done with that? I'll bet you that's good, but I'm not going to do it. Functional, we're running out of time. Okay, we'll stop it here. I'll try to record some of this material to clarify. It's probably better if I do that basic stuff now and then get into the physiology. So I'll just probably do the anatomy review and send that to you.